A lot of people say that the purpose of the prostate is to keep urologists employed, but increasingly I'm wondering if the purpose of the prostate is to allow Dr. McNeely to make jokes about the department. So the objectives today are to identify the leading theories of BPH pathogenesis to sort of contextualize the research that's going on in this area. And we'll look at some of the obstacles and why it's been difficult to make progress in BPH translational research. And we'll look at a personal interest of mine, which is the role of glucocorticoid-induced pathways as a candidate for being involved in BPH pathogenesis. To this end, we'll start by looking at the development of BPH in male LUTs, the histology of BPH and omic approaches that have been taken. And then we'll do a brief overview of those leading pathophysiologic theories, ever popular androgens, estrogens, fibrosis, inflammation, and infection as a lead into some of the glucocorticoid research that I've been looking at, and the role of budding and branching in BPH. To take it back to pediatrics, BPH embryology and anatomy is in utero differentiation is driven by androgen, specifically DHT, dihydrotestosterone, which, as you all know, is produced by the conversion of testosterone to DHT. The prostate begins as 5 ducts from the urogenital sinus that later fuse, and these ducts are not histologically distinguishable in the adult. They're surrounded by the fibromuscular stroma that we call the capsule, and initially, the transitional zone, which is the site of BPH, actually only makes up about 5% of the prostate volume. And then, of course, the peripheral zone is the site of prostate cancer. What happens to the prostate as men age is over the age of 40, you start to see the prostate growing in size. And nearly all of the age-adjusted volume increase is actually taking place in the transitional zone. So if you look at the total prostate volume, which is going up and up and up, on average for men up, this is a graph showing up to age 70. If you were to subtract the transitional zone changes, it actually doesn't grow very much. So almost all of the age-associated change in volume is happening in the transitional zone. And along with that is a morphologic change in the prostate. So many of you are looking at MRIs of men as they get older. And for those who are having BPH, that transitional zone really pushes and crowds out the rest of the prostate. You can kind of get a flattening and a thinning of the peripheral zone. BPH is a complex disease in that what we are describing clinically is a manifestation of symptoms, which is male lower urinary tract symptoms that may or may not actually be related to histologic BPH. And this is a classic BPH graph here where you have the Venn diagram of men over 40, some of whom have histologic BPH, which is always misspelled in this figure. I didn't make it. And then there's benign prostate growth and the male LUTs, and all of these may or may not overlap or be caused by other causes as well. The major, but not the only contributor to the bladder changes is BPH, which is the focus of this talk, but just this is all taking place in the context of many other causes of male LUTs. And the bladder, of course, is an important factor in the manifestation of the symptoms, because the symptoms that we're seeing are often the cause of the bladder weakening or decompensating over time. The response to bladder outlet obstruction is hypertrophy, muscle enlargement, collagen deposition, and the elasticity and compliance decreases from the increase in connective tissue deposition. Initially, as the bladder is pushing against this constricted urethra, there's a compensatory phase, and this is eventually followed by decompensation related to decreased detrusor blood flow, impaired tissue oxygenation. And this is apparently true in humans based on near-infrared studies. The timeline of irreversible hypertrophic changes is yet to be delineated, and that's the subject of some ongoing research. But essentially, this is just reinforcing that the symptoms that we're seeing well from the prostate are a manifestation of bladder changes, which does seem to play out clinically. This is a study from the late 90s, which is some of the evidence that the decompensation can affect your long-term outcomes. This was back when you could randomize patients to TERP or watchful waiting of 556 men who had a 60-month follow-up, and there was a treatment failure it was higher in the watchful waiting compared to TERP group. So these were men who had fairly significant lower urinary tract symptoms. There was a fair number of men who crossed over from the watchful waiting group to the TERP group. And the interesting thing about this is those men who crossed over had less improvement in their symptom score and objectively their flow rate compared to the TERP patients. And these happened at a delayed, in a delayed way. So you could imagine that those patients had a little bit more bladder decompensation, then crossed over to TERP and had worse outcomes. Of course, there are a ton of potential confounding variables there. Perhaps those patients who chose to cross over from watchful waiting had worse symptoms overall, or were otherwise more likely to be dissatisfied with their symptoms. But this is some clinical evidence that those bladder decompensation changes could be affecting your outcome. And so that takes us to the translational challenge in BPH number 1, which is that although the disease we're focusing on has to do with the prostate size increase or constriction of the urethra, which drives male lower urinary tract symptoms, many other factors are contributing to these symptoms. And a 1 cc growth in the prostate doesn't correspond to a 1 milliliter change in flow rate or a change in the IPSS score. You're dealing with these these things that have a correlation, but have a lot of confounding variables. And this is true even for some, what we think of as firm clinical endpoints, retention, surgery, medications. These all have variable biologic causes and variable responses to those. People have tried to overcome this challenge through a variety of different ways, sometimes by focusing on extremes, like very large prostates, sometimes focusing on surgery, patients who have surgery and just looking at surgical tissue, but there are drawbacks to each of these approaches. Moving on to the histology of BPH. The prostate, as you know, is composed of this stromal component, which is predominantly smooth muscle, and the ductal component, which is made of basal and luminal cells. And BPH, as you can see here from this slide, has a predominantly nodular morphology taking place in the transitional zone. BPH was a disease that was previously predominantly thought to be stromal, and this was based on some classic studies looking at TERP samples, but the TERP oversamples the periurethral area, which has more stromal predominance. And we know more recently from whole prostate specimens that there are actually a fair number of histologic subtypes. You have this basal cell hyperplasia subtype, stromal hyperplasia subtype, and then a glandular hyperplasia, which is actually the most common of the 3 subtypes, which you can see here. This is sort of the basal, which is a non-nodular BPH, a stromal, which has stromal nodules here, and this glandular with epithelial nodules. And some of this, you can imagine this looks familiar for those of us who do transurethral surgery. You can really see the nodularity in some patients and not in others. And I think this corresponds really well to the histology. This phenotype does seem to matter. For men who had, this was a study done of 36 men who had an MRI and a prostate biopsy, and then were started on terazosin. And they actually noticed that there was a better response in men who had a stromal hyperplasia on their biopsy. So here in this graph is the change in Qmax for patients who are on terazosin, and that had a linear regression correlation with the percentage of stroma. And here, this table shows that the stromal patients versus the non-stromal patients had a better response for patients who had more stroma. Of course, this is, and what they were trying to do was show that you could diagnose this on MRI, which unfortunately wasn't the case. But I still think that this is a good proof of principle that the histologic findings can affect your outcomes and responses to medications. Although I don't think biopsy is going to be indicated anytime soon before these medications, since it's much easier to just do an N of 1 trial, see if it works, see if it doesn't. They're relatively reversible. In large prostates too, you can see differences in the type of histology that's manifesting. In this study, there were 36 TERPs and 4 enucleations that were analyzed and stratified by resection weight. As I mentioned previously, the glandular nodules dominated the histology at all the different resection weights. But for the larger prostates, the nodules were even more predominant than for the smaller prostates. So you're seeing a histologic difference for the very large prostates compared to the smaller prostates. And we don't know, but some of the authors were theorizing that could this be related to why we see 5-ARIs being more effective in these larger prostates, where you're getting some atrophy of those glandular nodules. Lots of alternative explanations could exist, such as the fact that in very large prostates, the same percentage decrease would represent a much larger relief of obstruction. And so that could also be why you see a better improvement to symptoms. This brings us to a second translational challenge in BPH, which is that we have this heterogeneity of a histologic phenotype, And this suggests a heterogeneity of an underlying pathophysiology. And so if you're looking at tissue for one single pathway driver of the prostate, as in many of the other diseases, including oncology, we're looking more and more at the fact that there may be individual drivers or multiple disease processes that are going on. And related to this is the fact that we've been taking up until now, and some more recent studies, looking at bulk tissue. And when we're having epithelial and stromal compartments, multiple cell types in each of these compartments, there are a lot of there's a lot of heterogeneity that's not being appreciated that could be driving the underlying disease. And histology only takes you so far. In the adolescents, there doesn't seem to be a histologic difference if you look at the peripheral and the transitional zones. They look the same. And transitional zone has been traditionally defined histologically after BPH develops. Up to 70% of men have this by age 70, and nearly everyone by age 90. But if you look using more recent techniques, including single-cell RNA sequencing, there is more insight that's provided, and you can see that there are actually some differences between these zones. This is a study that I like a lot. 3 prostate donors from young men, aged 18 to 31, and single-cell RNA sequencing and flow cytometry was performed from a variety of the different locations, including the prostatic urethra, and clustered into stromal, epithelial, and unknown cell types. In the same study, they then took samples from each of the zones. So they took peripheral zone, central zone, and transitional zone. And they looked and they could see that there actually is a difference in the peripheral zone here in gray versus the transitional central zone in these different cell types. So more basal and luminal in the peripheral zone, and more club and hillock, which I'll talk about in a moment, in the transitional zone and central zone. So even though you can't see a histologic difference between the zones, the single-cell RNA sequencing is showing a difference in the cell types that are being expressed in that location. And this also bore out on flow cytometry sorting. And interestingly, another nice thing that they did on this study is to show that some of the traditional cell surface markers that were used for flow cytometry to distinguish basal and luminal were actually not maybe as pure as people thought, now that we have the benefit of the single RNA sequencing. So this is showing us that although we've been relying on histologic differences and showing that manifestation of the phenotype, structure dictates function, this may not be capturing what's happening earlier, where there are still differences between these zones. These hillock and club cells are a relatively new theory in the field, I would say, where they're named after cell types that are homologous to cells in the lung, which are called club and hillock cells. And the lung club cells have this cell surface marker with a similar transcription profile as well to the club cells in the lung. They have an immunomodulatory role in the lung. Their role in the prostate has to be delineated still. And then the hillock cells, once again, are similar to the lung hillock cells, KRT13 positive, and a similar transcriptome as well. And the interesting thing about KRT13 positive, which many people in the room would know more about than I do, is that these are enriched in prostate tumors, and some of the genes that are overexpressed in these cells are actually associated with androgen metabolism pathway, this AKR1, C1, and 2. So these two cells, some authors have hypothesized, could be bringing us back to the classic McNeil hypothesis from the 70s and 80s, that there is some stem cell reawakening that happens in BPH, and it's been suggested that these could be some of those early progenitor cells that are taking place in the transitional zone and having this reawakening that are sort of more active epithelial cells. This brings us back to some lineage tracing in the prostate. The prostate is this glandular branching structure that has all these glandular subunits that eventually drain into the urethra. And there's some question, where's the propagation coming from? One might think that it's coming from proximal to distal, but nobody has proven this until now. This study here from 2017 did some clonal mapping through a technique looking at cytochrome C oxidase deficiency mutations, and you can trace back those mutations in the mitochondrial DNA to figure out where the original clone is. And this does seem to happen from proximal to distal, so that the cells are, when they are first generated, start at the proximal branch and then branch out distally into the prostate. And so once again, this brings us back to those club and hillock cells and the transitional zone moving outwards, that maybe this propagation is happening proximally and then moving out distally in the transitional zone. BPH, some of the modern multi-omic techniques that have been used. The genome in BPH is complicated. Once again, we know there's a strong hereditary component to BPH. We see this in the clinic all the time. You know, my dad, my grandpa had this problem, and there's an increased risk of 1.5 to 1.7 with first-degree relatives in BPH. And a 49% heritability has been estimated from a twin study in the US military, 256 twin pairs. There's the usual caveats for these genome-wide association studies where you have a huge population looking at SNPs associated with a given disease, including the fact that how is this diagnosed clinically based on all the complexities with male LUTs and BPH. But a meta-analysis of 74 of these studies found that there were 5 statistically significant associated genes. The most interesting, this is a glutathione, transferase, ELAC2, and then TERT, which is sort of interesting because it's associated with telomeres, which BPH seems to be a disease of aging. And then there were some protective genes associated, including ACE, which you will recognize from ACE inhibitors. And then a more recent SNP association study of 500,000 patients also found that there were some genes that were both associated with heredity and BPH and prostate cancer, including TERT from the above study. Again, you have to take all of this with a grain of salt, and it's more hypothesis generating than hypothesis testing, because this can be from co-diagnosis of lower urinary tract symptoms, which can be maybe initially diagnosed as BPH and then turns out to be prostate cancer, or is prostate cancer and then gets a co-diagnosis of BPH. But it does help perhaps point the arrow in the right direction for some of these pathways. BPH is sometimes looked at similarly to the closest female analog, which is uterine fibroids. Uterine fibroids do have some mutational drivers, however, and some groups have looked to see if those mutational drivers are taking place in BPH. Does this seem to be more of a somatic disease, or are there mutational drivers? The answer is no, there doesn't seem to be mutational drivers. And this is a group that used that technique that I mentioned earlier to try to focus on the very large prostates. These are 18 samples from very large prostates, over 100 cc's, who had BPH surgeries, versus age-matched controls from the normal transitional zone from radical prostatectomy specimens. And this is another translational challenge in BPH, which is getting tissue to analyze and making sure that it represents the disease, and also getting appropriate controls. And how do you define controls? That's been a challenge for every group. People approach this differently. One way to do it is to take tissue from patients who have had surgery for BPH, which seems safe, but as I mentioned, there's all that heterogeneity in who's getting the surgery, why they're getting the surgery, what their histologic subtype is. And then importantly, the age-matched controls is all over the place for good reasons. You can't get quote unquote normal tissue from healthy volunteers except in very rare circumstances. What some groups have done is exactly this, taking the normal transitional zone from radical prostatectomy specimens for low volume, low grade prostate cancer. Of course, these patients tend to be a bit younger, and there is the possibility of having a field effect from cancer. Another approach is to take benign prostate from cystoprostatectomy specimens, which is a nice way to do it too. But again, those patients tend to be significantly younger on average than what you have available for BPH. And then there have been other people who take peripheral zone as a control, but as we know, there are some differences in the expression profile of the transitional zone versus the central zone. Or you can take healthy donors who are much younger. Once again, problems with every approach that you can have, and you just have to make do with the best that you can. But all of this needs to be looked at through that lens. But anyway, the whole genome sequencing, RNA sequencing, and DNA methylation was looked at this normal, quote unquote, normal transitional zone from radical prostatectomy specimens. Oh yeah, that's the other thing too. For the control tissue, if you're taking normal transitional zone and it's from younger men, you may just be comparing early versus late BPH. And if you're looking for a difference in the mutational drivers or the transcriptome, you may not see it if the disease process is happening, but just hasn't manifested completely yet. But if you have this whole genome sequencing, RNA sequencing, and DNA methylation looking at the two groups, there were significantly fewer copy number alterations in BPH compared to common malignancies, and this was compared to this large study, the TCGA study. So you look here, BPH is on the left in terms of copy number mutations, and all of these other cancers is much higher. So it's not having a neoplastic profile in the genome. And the genomic signature that you can see in the BPH samples, this green bar here is a signature that corresponds to age. And so the most of the changes, if any, that you're seeing in BPH are age-associated changes. The transcriptome was looked at, and there was a difference in the transcription signature between BPH and controls. Here you can see in that heat map. And that was validated in external cohorts as well. There was an AR downregulation, interestingly, observed relative to controls, although many of the patients in the BPH group have been exposed to 5-alpha reductase inhibitors, which would decrease the androgen pathway. And again, you don't know if are these prostates getting very big despite the downregulation of the androgen receptor pathway, or have they received 5-ARIs so late in their disease course that even though we have current downregulation of the androgen pathway, it's just too late, and you have so much obstruction that the bladder is decompensating. And so you can't draw these one-to-one comparisons where you say, well, AR is downregulated, so it's not important. Who knows? There's many different possible explanations for this. There was a KRAS signaling inactivation, which was identified inconsistent with the neoplastic process. And there's upregulation of BMP5, which is part of the TGF-beta superfamily. DNA methylation was also assessed through this technique, which is enhanced reduced representation by sulfide sequencing. And hypermethylation dominated in BPH here in the pink, once again compared to controls. And this was confirmed transcriptomically that if there was a methylation signature in the promoter, that was doing what you might expect, which is to downregulate expression of this transcription. And this hypermethylation profile, once again, is very consistent with aging.
What were the controls for this testing?
This is that study that used transitional zone from radical prostatectomy specimens. So yes, there are problems, but I feel like every group is doing the best that they can. You have to look at all the data in aggregate. And that's what we did too for our controls at Vanderbilt. It's easily accessible tissue. Other groups have done the cystoprostatectomy thing, but normal tissue would be great. Transcriptome and methylation, I just did this one. The overall molecular profile, looking at these two transcription signatures, identified an A and a B signature. This is somewhat interesting. It's a stromal signature that was identified, but this is without histologic stromal increase. So you're seeing the types of genes that would be upregulated in the stroma, but histologically not seeing an increase in the stroma. So could this be representative of a stromal overexpression or stromal overactivity without that histologic increase? And that's consistent with some previous reports. We talked about how there's the AR downregulation, but there are multiple possible causes of this, and that they found that BPH is a non-neoplastic process. Ultimately, from this large multi-omic approach, you get this list of potential signaling pathway candidates, including cholesterol biosynthesis and lipid biosynthesis. This one I thought was interesting, digestive tract development. That may come back to some of the budding and branching and the stem cell reawakening that has been hypothesized to be involved in BPH before. And then there was this B group of signature, which the main type of pathway that was upregulated was this regulation of blood circulation pathway. So these are potential candidates for exploration in the future. So another translational challenge, this is probably more like number 5 that I've talked about than 3, is that BPH does have this high heritability, but we haven't really identified specific targetable genes associated with this heritability. And we're yet to identify new targetable pathways through molecular profiling. Again, is this an issue with patient selection? Is this an issue with the types of controls that we're using? Does this have to do with the heterogeneity of the disease? Ultimately, you can do a lot of profiling to tissue, but unless you can make the argument that the tissue is representing a normal and abnormal state, it's hard to draw conclusions. So we'll go on to some of the leading pathophysiologic theories in BPH, looking at androgens, estrogens, fibrosis, inflammation, and infection as a lead into the theory I'm interested in, which is the glucocorticoids. And this will just be sort of going through them quite quickly. Each of these by themselves could be a thesis. So we talked about how these multi-omic approaches, they really give you a data overload. You have this huge readout of many different potential pathways that could be spit out when you're doing these as transcriptomic approaches and genomic approaches. And it's really nice to have a theoretical framework from which to approach the data, so you have some sort of biologic idea of how to interpret the various many pathways that are upregulated and sort out the signal from the noise. There are many of these theories that are looked at all over the world. Sex steroids is a popular one because of one of the few things we know is about the role of androgens. Fibrosis and inflammation and infection have been discussed as well. We talked about this epithelial stromal proliferation theory, reawakening of adult tissue, although we don't have a lot of evidence about increased cell division, which has led some people to talk about an imbalance between apoptosis and proliferation, which I won't really get into today. A lot of our understanding of the prostate comes also from animal models, which are a useful tool in that they're accessible, but the rodent models that are underpin a lot of our understanding of the prostate have this lobar prostate that doesn't have a known homology to the different prostate zones. And this is another challenge, which is not unique to BPH, which is that your models are models. You don't have, although they're very useful, they don't necessarily represent exactly what's going on in humans. Androgens and BPH are something that we know a lot about. We talked about how the prostate growth is non-linear in young males, seems to sort of increase as they get older, and how there's that differentiation that happens in utero, prostate from age 1 to puberty. The testosterone levels drop, prostate growth seems to not be going on during that time, and then starts to grow during puberty again. Prostate growth doesn't seem to do a lot between age 20 and 40, and then starts to grow again after age 40. Androgen is still required during that time, however, to prevent the atrophy of the gland, and the turnover of cells throughout the glands increase. Interestingly, then, the rate of growth seems to increase later in life, even though your testosterone levels are dropping off. Looking at one of it, yeah.
So I have a question, and more for Dr. McNeely. How come in a lot of patients with spina bifida and things like that, they get a hypoplastic prostate? Do they? Because isn't that what happens? Or when you look in, it just seems so small in that prostatic area.
Do they actually have an atrophy of the prostate?
Yeah.
Yeah, me neither. No, that's a really interesting question. You'd wonder if they could have something to do with, it's all midline, right? So midline.
Well, they do have an abnormality in their hypothalamic pituitary axis. They actually have precocious puberty because of that, presumably related to the hydrocephalus. And then maybe that has some impact on their estrogen, progesterone, testosterone axis that affects BPH production. I don't know. It's probably a central hormonal problem or a lack of problem.
Do you know if you see, for people with precocious puberty, do they get hyperplasia, like precocious hyperplasia and then atrophy?
I don't know, because it's picked up and then arrested, usually by the endocrine team pretty early on. So you'd have to find out 40 years later what's going on with those patients, right?
No, that's a really interesting point. But looking at this BPH model in dogs, castrated beagles were able to have prostate volume decrease by over 4 months. So this really drives home the fact that without androgen, the prostate will atrophy. So ultimately, if you wanted to castrate everyone, BPH wouldn't be a problem. Not recommended.
That's prepubertal, right?
Yeah. And when you expose castrated beagles or not to testosterone, androstenedione, DHT, or estradiol, all of these could induce a morphologic change in BPH and quite a striking prostate increase. Interestingly, this effect size was largest with the estradiol. These dosages are all extremely supraphysiologic, and so probably causing mayhem on the hormonal pathways. And this is also confirmed in more recent studies as well. Like beagles given DHT had a significant growth in their prostate. But underscoring the limits of the animal models, a study where this was done in humans with healthy volunteers who signed up to get testosterone, had their testosterone levels go up, but no increase in their transrectal ultrasound volume or PSAs across group. This is in young men. And so testosterone alone over the short period of time didn't drive BPH in these men. Can't be sure about older men.
Yeah, why don't you check men who weight lift and have reached a certain level
Of testosterone. Yeah, absolutely. I think that's one way to do it. But at least unlike in the animal model, you're not seeing a huge increase. Yeah, next to the bench, you could do the control of men who bench and men who are on the Stairmaster. Spin class, yeah, that lowers your T, right? And then meanwhile, there's conflicting data in humans about these longer term studies of testosterone and BPH size. So serum testosterone based on 4,000 men from a dutasteride for BPH trial in the early 2000s, the baseline testosterone levels, coming back to Miles's point, didn't seem to correlate with the overall prostate size, although that's just one snapshot in time. But in another study in 1,000 men, serum DHT levels were correlated to BPH risk in 1,000 men with a mean follow-up of 8.4 years, with a higher testosterone in the highest quartile being associated with an increased odds ratio of BPH, and same thing with DHT. That was across quartiles for DHT. But then on the other hand, in the original reduced trial, going back and looking at serum T and DHT levels, these weren't associated with progression of symptoms for BPH. So where does that leave us with androgens and BPH? Castration leads to involution of the prostate. So without testosterone, the prostate is not going to develop BPH. And that suggests that T is required for the disease to progress through the conversion of testosterone to DHT. But this may or may not be the primary driver. And even though testosterone is going down later in life, that's the time when the prostate is growing and DHT remains high in prostate tissue itself. And serum testosterone doesn't seem to be associated with baseline prostate size. The conclusion is this is, I think, one of the few things that most BPH researchers are agreeing on, which is that androgen seems to be playing a permissive role. You need androgen, but it's not necessarily sufficient to drive BPH by itself. Estrogens are something that we look at in part because testosterone and estrogen levels decrease as men age. And so a lot of people have wondered if it's the ratio of testosterone to estrogen that could be driving BPH. And once again, this has some conflicting data to it. Theory is that testosterone is converted to E2 and androstenedione, which is part of this pathway, is converted to E1. Both of these have affinity for the estrogen receptor, which is very complex. There's estrogen receptor A and B. The very short version is that alpha may contribute to proliferation and beta may contribute to apoptosis. And this, with the proliferation mostly happening in the stroma, apoptosis happening in the epithelium. Once again, clinically, this is of interest because we know metabolic syndrome is associated with BPH, and adipose tissue can cause higher levels of estrogen. Or is this just the neurovascular disease associated with diabetes causing male lower urinary tract symptoms? Probably both. Some of the evidence for estrogens comes through this study, which looked at the fact that 30% of men have a reduced 5-ARI type 2 expression through this SRD5A2 gene, which is through methylation. So you can see there's a difference. 30% of men are actually negative in terms of expression. In those men, the testosterone is higher, as you might expect, because this is a lack of the gene that would convert this to DHT. So you have higher T, lower DHT, and then higher estrogens as well. And the aromatase seems to be more active. So aromatase converts testosterone to estrogens. So the idea is that this reduced expression of SRD5A2 might be giving more precursor, which can then be shunted over to the estrogen pathway. It's a good theory for BPH, but there are always issues with every theory, and one of them is shouldn't having reduced SRD5A2 be exactly like being on a 5-ARI, and shouldn't that be protective against BPH because you're getting the reduced DHT expression? So there's that question that sort of hangs over everything. Selective estrogen modulators have been able to reduce the proliferation of cell lines that are induced to grow with estrogen. And so there's some basic science support for estrogens for sure. But as I said, there's a lot you could say about those. And the summary is there's conflicting evidence. Fibrosis in BPH has been brought up as a cause of the symptoms. This is supported clinically by the fact that there's mechanical stiffness associated with LUTs in periurethral tissue on men who had a radical prostatectomy specimen. This is independent of age or prostate volume, but the extracellular matrix content was found to be similar in BPH and normal prostate tissue, and the overall collagen content is not different between the two, except for this one subtype of type 1 fibers. And fibrosis didn't seem to be associated with fiber ARIs or alpha blockers. So again, conflicting evidence there. Inflammation and infection. This is a popular one with the ability for us to look at microbiome studies and assess to see if there's associations with different types of bacteria and all sorts of different diseases, including BPH. Inflammation on pathology from some of these large studies where they had to do prostate biopsies throughout in the early 2000s when they were looking at new medications showed that the inflammation on pathology is associated with worse sporting symptoms and is associated with some fibrosis and collagen deposition. But any attempts to link urinary symptoms and prostate bacteria is confounded by the fact that men with BPH have a higher post-void residual on average and would be more likely to be harboring bacteria. So you have this chicken or egg question, where is it the prostate growth which is driving increased bacteria? Is it the bacteria that's driving prostate growth, or is it this vicious cycle? And it's very hard to prove causation. I think there is some proof in the pudding in that treating men clinically with antibiotics has been tried many times, and it doesn't seem to prevent BPH from manifesting or developing. Large studies looking at NSAIDs have also not been successful, these COX inhibitors. Although I would say, and I don't know if Dr. Patterson, Dr. Chu have found this as well, there's a subset of men who seem to really swear by this and really respond to it. And I see it often enough that I wonder if there's a clinical subtype that's yet to be characterized that does respond really well to anti-inflammatories. And perhaps we haven't been able to detect this because of the clinical heterogeneity in the larger studies we've done. Related to inflammation is some work from my fellowship looking at prostaglandins in BPH. We found that prostaglandins were significantly elevated in BPH tissue from patients who required surgery compared to controls. The control in this case was transitional zone tissue from radical prostatectomy specimens. And prostaglandins are notable because they may increase smooth muscle contraction. We found there was an increase not only of the prostaglandins themselves in the surgical BPH patients compared to the incidental, what we're calling incidental BPH patients, but also an increase in the transcription of enzymes that convert PGH2, which is a precursor of these active metabolites, into these active prostaglandins. But again, clinically, we haven't seen a lot of success with COX inhibition in treating BPH. Could this be because of the heterogeneity of the disease, or is this just because this is not truly a contributor? In the last few minutes, I'd like to talk about glucocorticoids and BPH. And a lot of this has been context for this, what is an early avenue of inquiry in my program, which is to say there are a lot of different theories of BPH, all of which have conflicting evidence. And this is one that we can look at and embark upon that will probably also have some conflicting evidence. But hopefully we can learn a little bit about the disease process and proliferation in the process of this. So as we talked about, fiber ARIs reduce the conversion of T to DHT, and they are very effective clinically in the progression of BPH. An interesting thing about fiber ARIs is they also inhibit the degradation of glucocorticoids. So for this study, we looked at the transitional zone from patients who had surgery, compared that to the transitional zone from radical prostatectomy specimens, powdered it up and did RNA sequencing. And then based on the initial results, did some in vitro studies to help to confirm our findings. So for steroid synthesis, we're starting from these cholesterol pathways. As you recall, the cholesterol pathway was one of these things that was a potential signature in the BPH-A group from an earlier multi-omic study. And in this cholesterol pathway, you have the classic pathway of testosterone production through the testis. 5 ARIs block the conversion of testosterone to DHT. You have this backdoor pathway that occurs in the tissue with, once again, 5 ARIs blocking the SRD5A1 and 2 in the conversion of progesterone to androstenediol. And for patients who are on 5-ARIs, you're going to get an accumulation of this precursor here and also here, and these can be shunted through this possible 5-ARI induced pathway into deoxycortisol and then these glucocorticoids. And once again, 5-ARIs for patients who are on these are also resulting in an inhibition of the degradation of these. So you get precursor accumulation, which could be shunted over to that pathway, whose degradation is then inhibited. And we did see that pan out in mass spec. So here, for these various precursors, were down on average in surgical BPH versus incidental BPH. But then right before the conversion in the classic pathway, you got an accumulation of these precursors and a decrease in DHT. So this is showing that the 5-ARIs in patients who are on these are working. You're getting decreased DHT and increased testosterone. The same thing is seen in the backdoor pathway, where you're getting an increase in the precursor just before the inhibition by 5-ARI and decreased DHT. Then in your next slide, the 5-ARI induced pathway is showing an increase in the glucocorticoid levels themselves. So you're getting an increase in active metabolites of cortisone and deoxycorticosterone, especially in those patients who are on 5-ARIs or combination therapy, compared to the group with who are incidental BPH or who are not on 5-ARIs. This wasn't consistent across all the different metabolites, but as a trend, you're seeing an increase in the glucocorticoids in patients who are on 5-alpha reductase inhibitors. So we took this clinical finding and brought it into the lab and did this 3D culture, which is growth of 4 different cell lines, 3 of which are pictured here in Matrigel, which gives you these spheroids classically. And when exposed to dexamethasone, which was found to be increased in the surgical BPH patients, they actually had this very striking morphologic change of budding and branching, which took place. And we managed to develop through this model an on and off switch, essentially, where you can have the non-budding and branching state versus the budding and branching state, which can be induced through a single pharmacologic agent. Did some confocal microscopy, so you can see that really, I think, quite interesting looking 3D structure of the branching, which would be quite different than the pure spheroid that you get without the pharmacologic stimulation. And here CD5 cytokeratin 5 is the red basal marker, and then there was a luminal marker that was not pictured here as well. These patients were different, admittedly. The surgical BPH patients tended to be older on average, and not surprisingly, they were more likely to be on 5-alpha reductase inhibitors, although that was part of the theory. And the prostates were also larger in the surgical BPH patients. So there are all these possible reasons that we might have seen differences. And as I said, this is also bulk RNA sequencing, which is affected by the composition of the tissue and involves many cells that are not necessarily luminal or basal purely. We did a transcriptomic analysis looking for key hubs that can be of interest for future targeting and research in the BPH patients, NOTCH1, NEO1, sonic hedgehog, and EGF. And in the 3D culture, AREG, IL-6, and this was the glucocorticoid receptor that we put in here. And it just shows the complicated pathways that may be involved in this budding and branching process, which I would like to hear in my initial line of inquiry in the lab. So what we found essentially is that patients who fail medical therapy do have suppressed DHT synthesis with 5-ARIs. So this indicates one of 2 things to me. Either they're having an androgen-independent process of BPH growth, or their androgen pathway is being inhibited too late in their disease process, such that they're already getting bladder decompensation, which is unacceptable to them. That 5-ARI-induced pathway may increase the substrates available for the glucocorticoid synthesis, which are then inhibited. So you see increased glucocorticoids in the surgical BPH tissue. And most strikingly, in vitro, you can induce this budding and branching using glucocorticoids in an organoid culture, which gives you an on and off switch that I think needs to be characterized further and compared with patient tissue. What is budding and branching in BPH? This is whether or not this is clinically relevant is an unsolved question, I would say, to be fair. It's very important in the development of multiple organs, including the prostate, lungs, and mammary glands. And histologically, BPH is characterized by this epithelial budding and forming from ducts. We talked about the potential role of multipotent stem cells or multipotent cells in BPH that could be helping to drive the disease. But I can't say that there's that we can necessarily say that this is the exact process that's taking place in the prostate in men who are forming BPH. The interesting thing about budding and branching is that this type of branching has been observed previously by other groups, and there were different types of budding and branching that were seen. Some of them were reported as happening spontaneously with certain cell lines. Others were reported as happening when exposed to an extract of prostate stroma. But for many of these studies, if you go back and look at the methods, the close examination showed that the media that they were using actually contained some glucocorticoid in it. And this was often the case. And so to me, that helps to bolster that this is a true phenomenon that may be of central importance to the at least development of the prostate. And by having this single pharmacologic agent that allows us to turn on and off this budding and branching state, it gives us a very pure on and off switch to examine and characterize further. And I'm interested in determining what the changes in the transcriptomic signal are doing at the different branch points in this structure. So to summarize, BPH is clinically, phenotypically, and molecularly heterogeneous. And it's difficult to be sure that the control tissue that we're using as part of examination of the disease is appropriate. We haven't identified genomic drivers, although we know that it's not a neoplastic process, or doesn't seem to be, and has hypermethylation predomination. Androgens, by all evidence, seem to be necessary for BPH and permissive, but not necessarily the only driver. And there are many different theories for why BPH is progressive in certain men, but not others, each of which has some conflicting evidence to it, some evidence in favor, some evidence against. These theories, each of them are likely useful to contextualize the large data sets we get from these multi-omic studies. My initial line of inquiry has to do with glucocorticoids, although we will see whether or not these turn out to have more evidence for them. And I certainly wouldn't close the door on any of the other leading theories as well. They're all theories that are being explored for a reason because of the evidence behind them. I think we have about 5 minutes for questions.